Welcome to this multidisciplinary conversation on peripartum cardiomyopathy. Dr. Alexander, I do want to ask you, as a specialist in cardiovascular diseases in women, just talk to us a little bit about peripartum cardiomyopathy.
So, years ago, I've been in this field a long time, and some of my friends who are obstetricians would say to me, "Oh, we don't see that many patients with dilated cardiomyopathy." And I would tell them, "Well, that's because you all are in a small group, and here we're in a large group of people that are being referred to us. So our maternal fetal medicine group see a lot more patients than, say, the primary care obstetrician would. And so that means that we are seeing a lot of patients. But I think it is also becoming more prevalent because we are recognizing it more. And the recognition of it has helped because now we have some means of treating it. Recognition is the main key to trying to treat those patients, though. The patients that are at high risk for developing peripartum cardiomyopathy. And we have seen this to be noted in patients that are at high African descent. So patients that are African Americans, they have a higher risk for developing peripartum cardiomyopathy. Haitians. So it's thought to have a genetic predisposition. So if you have a patient that has symptoms, and let's go back to the diagnosis. So any patients presenting with ejection fractions of less than 45%, that means they have to have an echo, right? And we'll get into that later. But ejection fraction of less than 45% would be considered and no other medical problems. No, doesn't have congenital heart disease or any other medical problems, would be considered peripartum cardiomyopathy if they presented in the in the trimester of pregnancy up to 6 months. However, you can develop peripartum cardiomyopathy in the first and second trimester if you've had a termination. So if there has been a miscarriage or something, that lady can also develop peripartum cardiomyopathy. So we're looking at genetics as high risk and also history, what they've had previously, and then we go to symptoms. And those symptoms for anesthesiologists with the stethoscope would be shortness of breath or the heart failure symptoms, sometimes wheezing or orthopnea, but the usual heart failure symptoms is what would lead you to believe that this may be a patient with peripartum cardiomyopathy.
Information. Dr. Morris, anything you'd like to add about that?
Yes, I just make one comment. When we have in the acute setting on labor and delivery, sometimes things are rapidly evolving. We have patients that present with acute severe hypertension, tachycardia, pulmonary edema, and hypoxemia. And so this acute picture of severe or preeclampsia with severe features and pulmonary edema is pretty frightening to both us and to you as anesthesia providers. So you're the first person called to the room where we have to start talking about management decisions, intubation, delivery, what medicines to use, how to control the hypertension. And so in the back of all of our minds, as we've had a case like this here at UMC before, we have to think about the tachycardia, the underlying possible diagnosis of a cardiomyopathy. And so if we use, and Dr. Alexander could probably comment about this a little bit more, but the use of beta blockers or certain anesthetic medications that you might use for intubation or for treatment of the mother, again, has to be with the thought that this could be an underlying cardiomyopathy. And if you dull the tachycardia, you may drop the function and really develop sort of more of an emergent issue. And we certainly have had that presentation before. So again, just something to think about in that acute phase.
Thank you for that information. Great points, ladies. Will you elaborate more on heart failure treatment for PPCM with some attention to bromocriptine?
Right. So this has been new, and if you all know that our European colleagues are a little bit further along as far as peripartum cardiomyopathy and also patients that have heart disease and pregnancy. And so they have done quite a few studies in related to this. What they found was that patients, they think that this is a vascular path problem, and that the prolactin serves as the breakdown of prolactin serves to injure the myocardium. And so the thought, initially they used mice, pregnant mice, and they gave bromocriptine to those pregnant mice that had a dilated cardiomyopathy. They improved when they were given bromocriptine because it inhibited prolactin excretion. So even in our European colleagues are telling the women not to breastfeed. Americans are not really into that just yet, and so we have not recommended that. But because bromocriptine stops prolactin excretion, we do see that there's been some improvement if you can get those patients early. So if you can start them within the first week or two of their diagnosis, postpartum, then those patients would improve tremendously. I think we're still getting on board as far here in the States as far as we using it. Now, if we use it, those patients have to use anticoagulants. They recommend anticoagulants. You don't definitely have to, but it's recommended, especially if the ejection fraction is less than 30%. They recommend using anticoagulants because it may be a procoagulant state as pregnancy and postpartum is. So we don't want any more problems.
So, Dr. Alexander, what is the prognosis of patients with PPCM, and how do you counsel your patients who have PPCM regarding future childbearing?
Okay, so now let me just say this one thing. The obstetrician is the first person that can recognize these symptoms. And our obstetrician sitting with us was the first person that says something is not right. Even this was postpartum for the patient, but the obstetrician was the first. So they also need to understand what the symptoms and the signs are postpartum. And so when that obstetrician recognized that, then that person was able to send the patient to the cardiologist. So recognition is essential in the treatment of these patients. After that, we can start with our usual protocols, because most of the ladies, some of them may have preeclampsia with this. Then it's easy for me. It's easier because now I can throw my blood pressure medicine at them, which is the same as our heart failure vasodilators. But if I got a lady that does not have hypertension and they're shocky, those are very difficult to treat. And so if the patient is shocky, then we're looking at other modalities. So bringing that patient to the unit, diuresing them, and if they're very shocky, they don't do well even with nitroprusside or dobutamine. You might end up having to take them to the lab to put an impeller in them to support them if they are in a shock state, if they're presented with cardiogenic shock. But we are fortunate that most of the patients are not shocky, but they may have congestive heart failure, but not shocky. But those are the extremes. Now, if we have the extremes, sometimes you have to transplant those ladies as well. They don't do as well as, say, our patients with dilated cardiomyopathies from idiopathic dilated cardiomyopathy. It's an acute setting. They've done studies on these patients where they've biopsied their myocardiums. They took these are old studies, like in the 80s. They took a segment of patients where they biopsied the myocardium of the patients with peripartum cardiomyopathy to look to see if they had any evidence of inflammation. They did compare to the peripartum, compared to the dilated cardiomyopathy that were idiopathic. There was a little bit more inflammation in those patients. I don't want to go into total detail, but the good thing is that if you can get through the medication, the majority of the patients improve to get back to normal life. Now, after that, you ask me, what do I tell the patients after this? That's the hard part, because take, for instance, you've got a mom, first time pregnant, and she wants to have some more children, and her ejection fraction goes back to normal. So it is unfair for me to scare that lady and say, you don't need to get pregnant at all, because the data is not good. Okay, so what we do recommend, that sometimes we would want to stress those ladies, do a stress echo on them. If the myocardium is gets better doing the stress echo, they should do fine. I'm talking about ejection fractions of over 55%. Then they may do okay with the next pregnancy. But the mom and family has to understand there's still a increased incidence of it recurring. Now, the people that are less than that, in the 30% range, we don't recommend repeat pregnancy.
Dr. Alexander, would you like, Dr. Morris, would you like to add anything regarding counseling the patients, future childbearing?
So I completely agree with what Dr. Alexander has said. These are sometimes the hardest conversations, I think, to have. We sometimes don't get the chance to talk to someone when they're not pregnant and they've had this history. Certainly the first 6 months after the diagnosis of peripartum cardiomyopathy, that's when it's going to be about as good as it gets. And that function you've regained then predicts how you'll do for the rest of your lifetime and how you might do in a future pregnancy. If the function's not regained and it's not normal, we talk about risk to pregnancy, whether it's, again, worsening heart failure, an arrhythmia, or some other kind of cardiovascular morbidity and mortality. And again, generally, we don't advise pregnancy again if the function is poor. We have had mothers that, have had ongoing pregnancies with poor function. And we'll get into this a little bit more about the collaborative approach, where we're seeing these patients every week or two. Again, it's not advised that we do this, but we have been in that situation before, so we're still learning. But in general, if the function remains poor after a diagnosis like this, I don't recommend, again, subsequent pregnancy. Sometimes I don't get that conversation or choice, and so we're left with, moving forward and what do we do? So, and how do we best manage them so we have two survivors? So.
Dr. Morris, you are a member of ACOG, American College of Obstetricians and Gynecologists, and significantly, the chair of UMC's Department of OBGYN, Dr. Marty Tucker, is actually the current president of ACOG. Would you talk to us about current ACOG recommendations regarding postpartum follow-up for patients who are at high risk for cardiovascular diseases?
Absolutely. So that's a great question. So ACOG has several documents that suggest that we should be following our mothers who have any kind of hypertensive diagnosis, whether it's gestational hypertension, chronic hypertension, preeclampsia, within the first week of their postpartum discharge diagnosis. So the purpose for that visit is to identify these red flags, the things that don't fit with just a general hypertension diagnosis. There's also this just description of the care team. So depending on how complex the patient is or what they have, you incorporate other, care providers in this postpartum care timeframe, because that's honestly when the patients are greatest risk for having complications, whether it's thromboembolic disease, again, peripartum cardiomyopathy, or postpartum depression. So it includes the pediatricians, again, us, primary care providers, so all of us to try and optimize that postpartum care. And then ultimately they do come back for a 6-week checkup, but there should be so much more that occurs in those first 6 weeks. It's not just see you later. It's just about optimizing what they need, medications, blood pressure checks, et cetera.
Well, we know that, multidisciplinary communication is so important. That's really been our motivation for this. Walk us through, if you will, our institution's approach to multidisciplinary management of such high-risk patients.
So I've been here, and Dr. Alexander, you joined in for 13 years. And so over the last 13 years, the communication between obstetrics, maternal fetal medicine, cardiology, and congenital cardiology has increased exponentially. also our other care providers, our anesthesiologist, our obstetric anesthesiologist, our cardiac anesthesiologist. So we've had so many cases that we've seen here where we have to collaborate: delivery in a cardiac suite, the care of the mother, placement of a Swan-Ganz catheter in the echo lab, so there's just so many things. So this just continues to build, the intensity continues, and so this collaboration just continues to formalize where all of us are communicating, whether it's through Epic or cell phones or, again, in the clinical setting to optimize care. Again, multidisciplinary meetings occur, again, depending on the level of complexity on the regular, whether it's in the CICU, again, in the WISER, on the floor, at the patient's bedside. And these are just things that have sort of naturally taken place because we have just such excellent providers that are committed to the care and understand the complexities that it involves. So we're super fortunate for the people we have here. I'm glad to be a part of it.
Awesome. Dr. Alexander, would you add something, please?
Well, you know what? I got this actually from Dr. Morris. She likes to organize. I'm telling you. And we had a case recently that we had to organize. And I said, I'm going to do like Rachael does. She grabs us all together. So we got anesthesia there. We have the surgeons there. We have the cardiologist there. But it really has helped us pull things together. Before COVID, we were all sitting in a little room. Trying to, and Rachael would make us sit there every week. I said, you have to meet every week? Yes, but it helps tremendously. And then they're wondering, well, it went so smoothly. Why do we have to do all of that? But I think it goes smoothly because we did that.
Well, I mean, just awesome work you both are doing. I'm so honored, as many in the audience are. We're just glad to have this collaboration. And as we draw this conversation to a close, I think it's been great, but I do want to publicly and formally thank you again for participating in this conversation. And thank you for what you do, and thank you for your commitment. This is really an example of how patients can do well. And, when the patient's voice is heard and the right people hear the voice and make the action. So what closing thoughts or message would you like to share with us that you've not?
Goodness. I'm just thankful to be here. Certainly thankful to be a part of this, and thankful that you picked up the phone that day and called me and told me you weren't feeling well. Super thankful. Glad that I had the knowledge to know what was wrong with you, and thankful for Dr. Alexander to be able to call her out of an emergent meeting and say, I need you. She's sick and she needs you now. And for her to get you in quickly within like an hour of your phone call, and that we were able to figure this out, and that you're doing great, and that we're all here together.
Right. And we can do it for others too. I think that's the whole point, that we can now do this for others. We can still use those devices that you use to find out what your heart rate is. And we can recommend that for other patients as well. One other thing I want to say, I don't think we touched upon very much, but from a cardiology standpoint, most of our patients have been able to deliver vaginally without any problems. We didn't talk about that much, but unless it's an obstetric problem, from a cardiac standpoint, they have done well with that. So I tell my partners, you all stay out of that. Let them tell what mode they want to deliver, unless it's somebody with hypertrophic aortic stenosis, that kind of stuff. But we all kind of know the rules for those patients. Thank you so much, Dr. May.
Second stage, and use forceps or a vacuum or something to assist the mother's pushing efforts if for some reason, she's struggling around the time of delivery. So it's easy to do.
Well, thank you again for joining us. To our audience, thank you for your attention. It's been really informative and quite engaging, I think. And we hope that everyone has gained greater knowledge regarding PPCM diagnosis, awareness, recognition, and treatment as we continue to move forward in a multidisciplinary fashion. Remember, we're all in this together, and together we are UMMC Strong. Thanks, everyone.
Thank you.
Bye.
Bye-bye.